हेलो।
उनको आवाज आ रही है लेकिन वो भी अनम्यूट नहीं कर सकते। उनकी आवाज
नहीं, ओके। अब उनसे एकदम पूछ लें कि मेरी आवाज ओके है, स्टूडेंट्स को कोई इशू तो नहीं है।
स्टूडेंट्स अनम्यूट करके वो रिस्पॉन्स दे सकते हैं।
Yes, miss, आवाज आ रही है.
We can hear.
You can hear. Okay. Okay, let's start. And I'm about to start. And I'm Dr. Hira, and hopefully my voice is clear for all of you. And I'm today my topic is related to obstructive lung diseases, and I'm there. Obstructive lung disease is split into two lectures. Today is one lecture, and tomorrow morning at 9:30 a.m. is second lecture. Okay. In today's lecture, I will discuss emphysema, chronic bronchitis, and depending on time, if time remains, then I'll discuss bronchitis. Otherwise, I'll discuss tomorrow. So welcome all of you, and let's start. Obstructive. What is obstructive lung diseases? Actually, obstruction means there is something is trapped in the lung which doesn't allow lung to come the air outside. So obstruction of airflow resulting in air trapping in the lung. So what happens whenever there is air trapping in the lung? So there is volume trap in the lung. So residual volume is increased and lung having high volumes. So that's why in obstructive lung diseases, there is high residual volume and high functional residual capacity and high total lung volumes. So basically, first of all, these lung volumes are very important, and these are the part of physiology lecture, but I'll briefly touch these volumes for you guys, because the difference between obstructive and restrictive lung disease based on these volumes are mandatory. It's very important. You can diagnose either this obstructive or restrictive lung disease based on these volume, these capacities on pulmonary function testing. Okay, so I am just these are all lung volume and these are lung capacity. Lung capacity actually the sum of two volumes. So first volume is tidal volume. You can see here tidal volume. It means that air is coming on each inspiration is tidal volume, and inspiratory is a volume when air is breathing in after inspiration. Inspiratory is a volume, and when air is breathing out on normal expiration is expiratory is a volume, and it is quite normal breathing tidal volume is okay. And residual volume is what left behind after expiration. What left behind is residual volume. Okay, so these are different lung volumes, and hope you these all lung volumes are discussed in physiological lecture. And the sum of these two volumes are lung capacity. For example, the sum of inspiratory reserve volume and tidal volume is inspiratory capacity. The sum of expiratory reserve volume and residual volume is functional residual capacity. Then these two are vital capacity, and these three are total lung capacity. So what happened in obstructive lung diseases, because there is obstruction, patient can't breathe out properly, so the residual volume, which is normally this, it increases. Okay, and total lung capacity also increases in obstructive lung diseases. So on PFT, there are high residual volume, high functional residual capacity, and high TLs, high total lung volume, total lung capacity or lung volume. And what is this FEV1 to FVC ratio? That ratio is decreased, and that is a characteristic of obstructive lung diseases, because this ratio is normal or increase in obstructive lung diseases. So what is this ratio? This is the force expiratory volume in 1 minute versus force vital capacity. So coming back to this is again the volume flow volume loop of obstructed versus restrictive lung diseases. And you can I told you that all volumes are increases in obstructive lung diseases and all are decreases in restrictive lung diseases. Then forced expiratory volume in 1 minute is less than in obstructive lung diseases, is also less in destructive. Forced vital capacity is less than in both, but ratio is decrease in this as compared to normal or increase in this, because the decrease in forced expiratory volume is more in obstructive lung capacity as obstructive lung diseases as compared to restricted lung diseases. That's why the ratio of FEV1 to FVC is decrease in obstructive and it is normal, or increase in restrictive, because of this FVV1 is decreased more than FVC, and in restrictive FVV1 decreased proportionally. So this is the basic of obstructive and restrictive lung volume based on pulmonary function tests, and this is very important for exam point of view. You keep getting these things keep coming in your exam. About volume and what happened in obstructive lung diseases, because uh, there is obstruction, patient can't breathe out air, so there is chronic hypoxia. And what happened in lung, especially in pulmonary vasculature, whenever there is hypoxia, there is vasoconstriction. In other body, in other organs, whenever there is hypoxia, there is vasodilation, but pulmonary circulation is unique. In pulmonary circulation, whenever there is hypoxia, there is pulmonary vasoconstriction. So that leads to the core pulmonale. What is core pulmonale? Core pulmonale means the right-sided heart failure. Okay. So this is the complication of obstructive lung diseases, and these are volume. So this slide is again the repetition that force expiratory volume in 1 second is more reduced than forced vital capacity. So ratio is less than 0.7 generally. Now, how we classify obstructive lung diseases? There are four things: chronic bronchitis, emphysema, asthma, and bronchitis. So I'm discuss today chronic bronchitis and emphysema, and remaining two will discuss tomorrow morning 9:30 a.m. Okay, what is emphysema? Emphysema is actually I will show this picture later. First, I'll define definition: permanent enlargement and deterioration of airways distal to the terminal bronchiole. In emphysema, there is permanent enlargement of the airway. So what happened? There is destruction of the air wall. So whenever there is destruction of air wall, pulmonary capillary doesn't. There is also destruction of the pulmonary capillary. So there is decrease. Technical classification, there is distal SNR emphysema. There is, for example, pan SNR. SNR is the functional unit of lung, and pan lobular means there is destruction of whole SNI. Usually, pan lobular occur in alpha 1 antitrypsin deficiency. Okay. And this is the centrilobular emphysema. There is destruction of the central part of the sinus. Okay. So in emphysema, there is enlargement, deterioration of the airways. So this picture is more clear. This is the normal sinus, and this is the alveolus. This is the alveolar duct, and these are the respiratory bronchiole. When this center of involved, it is called centri-SNR, and when whole SNS involved, it is called pan-SNR. So centri-SNR is a characteristic of smoking, and this is due to the alpha-1 antitrypsin deficiency. And I'll discuss what are these two in my next slide. So, okay, whenever there is destruction of alveolar wall, and so what happened? There is decrease recoil of lung and increase compliance. What is compliance? Compliance is a change of pressure, change of volume for given change in pressure. Compliance means in how you inflate lung. When you, for example, lung is like a balloon. When you blow the balloon, you see there is inflation, and when the air goes off, it's again go back to the shape. So compliance means how easily lung inflate. And decreased recoil means that it's not going back to the normal volume, because why compliance is increased and recoil is decreased, because of destruction of alveolar walls. Okay, some students are raising hand. I don't know, I don't have comments why they are raising. Okay, if there is any question, I will take question and answer in last 10 minutes. Okay, if you have any issue related to voice or video or audio, you can type in the chat. Okay. So uh, decreased recoil or increased compliance resulting because of destruction of alveolar wall. So it is a feature of emphysema, and also there is decreased exchange of oxygen. There are DLCO is also decrease in emphysema. Okay, central SNR is associated with smoking, and it is usually involved upper lobe, and pan SNR is associated with alpha 1 antitrypsin trypsin deficiency that involves frequently lower lobe. Okay, so the central SNR on pan SNR is based on anatomical location of uh, which part of SNS, which part of alveoli, which part of lung is involved. Is it is based on this anatomical classification. Okay, and distal means paraseptal, which is the proximal portion of SNS involved, and distally part is predominantly involved. Then etiology is based on cause of either it is due to cigarette smoking or genetic predisposition. It means that there is deficiency of alpha 1 antitrypsin, which I discuss in my next slide. What is alpha 1 antitrypsin? And other are occupational exposure to chemical irritant and exposure to atmospheric pollutant. So this is a slide from your textbook. Okay, how destruction of alveolar wall occur in emphysema. Whenever there is any irritant, either it is smoking or air pollutant or chemical irritant, or there is genetic predisposition, which is due to the alpha 1 antitrypsin deficiency. What happened? There is a damage, there is a oxidative stress, there is an increased apoptosis, which causes inflammation, release of inflammatory mediators, and releases of protease. Protease actually is an enzyme, or elastase is an enzyme that is released by the neutrophils that causes destruction of the alveolar wall. So this proteases or elastase is inhibited by alpha 1 antitrypsin, which is normally present in our body, which is secreted by the liver. So this enzyme protect lung to the destruction that is occurring through these proteases. So whenever there is deficiency, congenital deficiency of this enzyme alpha 1 antitrypsin, there is increased chance of patient having emphysema in young age. If someone is some patient, for example, is a chain smoker, having might be they develop late in the life emphysema. But if someone having this congenital alpha 1 trypsin alpha 1 deficiency, so might they have developed emphysema earlier in the life. So there is protease or antiprotease imbalance, because we in our body there is deficiency of antiprotease. So there is protease and antiprotease balances. This is the congenital cause of alpha 1 antitrypsin deficiency. This is the congenital cause, and that's why the patient develop this type of emphysema, pan-acinar emphysema. Whole the acinus is involved, and usually patient develop relatively in the young ages. And these two causes are acquired causes. Due to some smoking or air pollutant, there is ongoing inflammation. So these three leads to the alveolar wall destruction. That's why the destruction of alveolar wall, that leads to the emphysema, that leads to the air trapping, increased lung volumes, FEV1 to FVC ratio is decreased, there is decreased recoil, increased compliance. So these these are pathogenesis is this, and that leads to the consequences. Now this is again a repetition of my previous slide, that the several proteases are released that from the inflammatory cells, and that causes a breakdown of the connective tissue. So whenever there is deficiency of alpha-1 antitrypsin, the patient develops emphysema. Okay, and now come back to the how patient present. Obviously, patient present with shortness of breath, patient present with hypoxia, patient present with tachypnea, there is tachycardia, and also in emphysemic patient, there is pursed lip breathing. What is pursed lip breathing? Pursed lip breathing is that patient try to exhale from his or her mouth, like when you whistle, like this, when you try to whistle like this. So what happened, why they are trying to exhale from the mouth? Because they are trying to lower down the pace of breathing. So that's when, because there is obstruction, there is lung trapping, so they try to lower down the pace of breathing, so their dyspnea, their hypoxia get better like this. So when you go to your clinical, your chest ward and pulmo ward, when you're rotating, during rotation of your clinical wards, you see that the COPD patient breathing pattern is like this. They try to their mouth like this. This is called pursed lip breathing. Or they also use their accessory muscles. We normally patient don't use their accessory muscles, but they use their accessory muscle. They try to expire the air which is trapped in the lung, and because there is trapping of air, there is increased anterior posterior chest diameter in chest X-ray. I'll show you the chest X-ray, and there is also the cyanosis. So what happened even by the time there is chronic hypoxia, there is chronic vasoconstriction of pulmonary, so that's leads to the right-sided heart failure, which is called core pulmonary. And what is the feature of right-sided heart failure? The GBP is raised, there is edema, the distended neck vein, there is edema, and sometimes the liver is also enlarged. And when you do the clinical exam on the emphysemic patient, because there is air trapping in the lungs, so the percussion note, what is the percussion note is, you can see that when you do the exam, this is called the percussion. You tap to your hand against the patient lung chest wall, and there's increased resonance, and the breathing pattern is when you auscultate the chest, there is a wheeze, and the breath sound is decreased. So this is the percussion become hyper resonant, and there is also wheezing. And what happened, the breathing sound is decreased. Why? Because there is air trapping, which cause the bronchial secretion and plugging of the mucus, inflammation. So their emphysemic patient also having risk of infection because of their continuous mucus plug, inflammation going on. And now why telling these clinical sign and symptoms, because these are important, because in pneumonia and in pleural effusion and other in pneumothorax, the findings are different as compared to emphysema. So when you go and read your books, you see that you can even based on patient history or clinical exam, you can even differentiate, or you can give probably you can tell the 2 to 3 differential diagnoses. For example, in the pleural effusion, the percussion node is dull. In pneumothorax, it is high, and in pneumonia, there is bronchial breathing. So these are a few points which helps you to tell 2 to 3 differential diagnoses or narrow down your diagnosis. Okay, and also when you chest X-ray is baseline investigation, and when you see the chest X-ray is like this. Why? This is normally when you compare chest X-ray of emphysema to normal chest X-ray, there is hyperlucent or more dark spaces in emphysemic patient. So there is translucent or dark lung fields. Why? Because there is more air in the lung. Air is trapped due to the obstruction, so which gives you the picture like that the lung, the chest X-ray is more darker. Okay, so you will able to differentiate when you see 2 to 3 the normal chest X-ray, and when you compare these chest X-ray to the emphysemic patient, and you can see that there is also blunting of these diaphragmatic surfaces, and the shape of heart is like tubular or narrow. So this is the very combination of flattened diaphragm, dark lung peaks, and long and narrow heart. So this is the very characteristic finding of chest X-ray of emphysemic patient like this: darker, more darker air, the narrow heart, the flattening of diaphragm. So these are the chest X-ray, and now the coming back to the key point. Key point is very important. Key point is what message you can take from the lecture, and then you go back and read your books. Emphysema is a chronic obstructive airway disease that is characterized by the permanent enlargement or air spaces, distal to terminal bronchiole. That is the component of chronic obstructive lung diseases, and its subtype includes centri, SNR, and pan-SNR. Centri SNR is due to smoking, pan-SNR is due to anti-1 trypsin deficiency. And what is the pathophysiology? That smoking and all the inhalant pollen cause ongoing accumulation of inflammatory cells, and releasing of elastases and oxidant which destroy the alveolar wall. And in an alpha anti-1 trypsin deficiency, there is an imbalance between proteases or antiproteases. So this is the emphysema. And if you have any question, I will take question in the end of my lecture. Okay, and chronic bronchitis, as the name shows, what is bronchitis? Bronchitis means inflammation of bronchus, and it is a clinical diagnosis. It is a definition. It means that there is a persistent cough with sputum production for at least 3 months in at least 2 consecutive years. So in the absence of any other cause. This is the definition of the chronic bronchitis. If someone having at least 3 months cough in at least 2 consecutive years in the absence of all other causes. There is also many causes of cough. Cough also happen in TB, in pneumonia, or in other causes, in pneumocinosis. So there is no other identifiable cause in chronic bronchitis with this definition. So again, you can see that cigarette smoking is the most important risk factor, and other risk factor are air pollutant, all that also contribute. So when you respiration module, you can see that the most of the risk factor are most diseases having risk factor having risk factor related to their smoking. So smoking is because why the smoking causes inflammation. The dominant pathological features are mucus hypersecretion and persistent inflammation. So because there is a chronic, there is a persistent inflammation, and because of their inflammation, there is hypersecretion of the mucus from the glands. So this is the pathological feature. And histology is very important. Why? Because it gives you the clue, because in histology gives also the clue and helps you differentiate from other disorders. So histology of all the these lung diseases is important. You have to know the 2 to 3 points that help you to pick up the scenario and help you to reach the diagnosis in the exam. For example, in this chronic bronchitis, there is enlargement of mucus secreting gland, and there is Glovert cell hyperplasia, and there is chronic inflammation and bronchial wall fibrosis. Because there is ongoing inflammation, so there is a hypertrophy of the mucus secreting gland, and because of there is hypertrophy of the mucus secreting gland, there is hypersecretion, there is Goblet cells hyperplasia, there is inflammation, and eventually that leads to the fibrosis. So this is the correct, this is the important histological feature. And what is the rate index? This is the actually, this is the called the thickness of mucus gland layer to the thickness of the mucus gland layer to the thickness of the wall between epithelium and the cartilage. The normal definition of radius index, thickness of the mucus gland layer to the thickness of the wall between the epithelium and the cartilage. Usually it is not, it is less than 50%, but if it is more than 50%, that is the chronic bronchitis. Because of why it is more than 50% in radix in chronic bronchitis, because there is hypertrophy of mucosal gland. That's why this rate index is more in chronic bronchitis, and this is also one of the exam question. Okay. Okay, so what are the sign and symptoms of chronic bronchitis patient? There is cough. Why there is a cough? Because there is hypersecretion, there is a mucus plugging, there is inflammation. This means there is a sputum in the cough. And hypercapnia. Hypercapnia means more carbon dioxide. So what COPD? If you do the ABGs of COPD patient, the arterial blood gases of the COPD patient, there is hypoxemia, means there is decreased oxygen. There is respiratory acidosis. What is respiratory acidosis? When the carbon dioxide is increased. Why there is carbon dioxide is increased? Because there is retention of carbon dioxide in the lung. Patient cannot breathe out properly. So there is high CO2 levels in COPD patient. There is hypoxemia, decreased oxygen. There is sometimes there is Marie cyanosis, which is called blue blotters in chronic bronchitis patient. Okay, and again all the COPDs leads to the core pulmonar. Why? Because there is hypoxia, there is vasoconstriction, there is increased congestion and resistance in the pulmonary vessels that lead eventually the right-sided heart failure. Okay, which is obviously the late complication, and death may also result from infection. Because what happened? Uh, because of ongoing inflammation, there is hypersecretion, all these things. So there is a risk of superimposed bacterial or acute infection in COPD patient. When you do the microbiology, you'll see that some viruses are prone to cause COPD infection in the COPD patient, and some bacteria are associated with COPD infection, associated with infection in the COPD patient, such as Pseudomonas. Okay. Now these are the this chart is good that differentiate between the predominantly bronchitis and predominantly emphysema. How you differentiate either it is bronchitis or it is emphysema. So you can see that dyspnea is more severe in emphysema. Why? Because there is more destruction of alveolar wall, and the presentation is early, but age is almost same. It's most early. It's quite late. And cough, when you see that cough section, so there is much sputum in bronchitis as compared to emphysemic patient. Why? Because there is mucus gland hyperplasia, there is hypersecretion. That's more in bronchitis. And infection is, that's why infection is more common in chronic in bronchitis patient as compared to the emphysema. And there is respiratory insufficiency is in both, and core pulmonary is also common in both, but that's more common in bronchitis as compared to the emphysema. And airway resistance is increased in bronchitis. It is also normal or slightly increased in emphysema. Why? Because in emphysema, it is I told you there is increased compliance and decreased required due to the destruction of the alveolar wall. That's why airway resistance is normal or slightly increased in emphysema as compared to the bronchitis. Okay, or elastic recoil normal at low, which we already discussed. And chest, when you see the chest radiograph, I showed you the hyperinflammation and small heart in the emphysemic patient, and there is in this is usually there is prominent vessel and cut in the large heart, or there is a sign of like maybe the superimposed someone having a superimposed infection in chronic bronchitis patient. So maybe some patient having pulmonary infiltrate, or you can see the consolidation. And appearance is mild cyanosis in the chronic bronchitis patient, and emphysemic patient are pink puffers. Why pink puffer? Why? Because they, what happened whenever there is hypoxemia, because this is more hypoxemia is more in emphysemic patient, that gives the signal to the kidney, and the kidney release erythropoietin, and that erythropoietin stimulate the production of the red blood cells. So there is maybe there is because that's why there is secondary polycythemia in COPD patient. Sometimes so they can present it like they having pink puffer features. Okay, we have I think now the next topic is bronchiectasis, and I will discuss bronchiectasis and asthma and atelectasis in my tomorrow lecture, which will be on 9:30 a.m. tomorrow morning. And here I'm finishing my lecture. If you have any question, you can ask me. You can type your question in the chat. Okay, representative. हेलो कामरा
जी हेलो
जी, मैं अब लेक्चर अपना खत्म कर रही हूँ, क्वेश्चंस आंसर्स ले लें आप।
हाँ ठीक है, ये स्टूडेंट्स जो है रेज हैंड ऑप्शन करते हैं, तो जो रेज हैंड करता जाएगा मैं उसको अनम्यूट करता जाऊंगा सीक्वेंशियली।
नहीं एक्चुअली आप कर दें, वो मुझे
अलाउ कर दो
जी नहीं अलाउ चैट अलाउ कर दें। मैं एक्चुअली वो मुझसे क्वेश्चंस आंसर्स पूछ रहे थे, रेज हैंड कर रहे थे, तो वो लेकिन क्लिक नहीं हो रहा था। आई डोंट नो आपने डिसेबल किया हुआ है।
अच्छा मैं इसको
उनके क्वेश्चन उनकी चैट इनेबल कर
चैट पहले चैट एनेबल कर दी है मैंने
जी। मैं अच्छा मेरे पास चैट मैं देख लेती हूँ कहाँ से।
ये नीचे ऑप्शन आ रहा होगा, नीचे की तरफ ऑप्शन आ रहा होगा।
मोर में आप जाएं तो मोर
अगर कोई क्वेश्चन पूछना चाह रहा है तो वो रेज हैंड का ऑप्शन कर दे, मैं उसको अनम्यूट कर देता हूँ।
अच्छा मैम इट्स ओके एंड योर वॉइस इज फाइन, ये लिखा हुआ आ रहा है।
ये वो स्टार्ट में फीडबैक दिया था उन्होंने कि जब आपने पूछा
अच्छा
था।
मैं अगर टाइप कर दूं तो आ जाएगा?
जी जी ये चैट पे भेजा एक क्वेश्चन।
Okay, what is the reason of superimposed? Achha. Okay, the reason of superimposed infection in chronic bronchitis is due to inflammation. There is ongoing inflammation, and whenever there is inflammation, there is hypersecretion, there is a plugging of mucus. So there is always risk of superimposed infection in chronic bronchitis. Why the same phenomenon? Because there is more hypoxemia in more emphysemic patients, so that's more present with pink buffer. Okay. Chest X-ray of patient of chronic bronchitis is variable. If chronic bronchitis patient having infection, pneumonia, superimposed. What is superimposed infection? Superimposed infection means pneumonia. So what is the finding of pneumonic patient of chest? What is the finding of pneumonia on the chest? So there is a consolidation in that patient. So there is okay, elastic recoil and compliance. Compliance means the compliance or recoil is it is the question from Nurul Huda. Okay, Nurul Huda, compliance and recoil is like for example, like a balloon. If you blow the balloon, you can see balloon is like this. It is a blown balloon. So air is fill in the balloon. This is called compliance. How easily air fill in the lung is compliance. Okay. And when the air is out from the balloon, that balloon go back to the this shape. Okay, that is recoil. Recoil means the one balloon is going, then the lung is going back to their shape. That is the recoil. So compliance in the easier word, compliance, how easier to fill the lung. For example, compliance is increased in emphysema patient. Why? Because there is alveolar wall destruction. So the compliance is increased. There is no inner resistance. Compliance increased, but compliance is decreased in fibrosis because lung are stiff. So that's why that's just compliance and recoil. Okay, diffusing. Okay, DLCO means lung. DLCO, who is asking is a Priyangang Kashik. Sorry of pronouncing your name. How can you explain DLCO? Okay, DLCO is DLCO means diffusing lung capacity of diffusing lung capacity of what, of oxygen. But how we monitor uh, DLCO we usually monitor as a surrogate marker from the carbon monoxide, but that is used for the diffusion capacity of the oxygen. So whenever you can see how whenever there is destruction of the alveolar wall, there is a destruction of the pulmonary capillary. So there is no exchange between the lung and the blood. So that's why the DLCO is decreased in emphysema. COPDs. It is not. Okay, clinical sign and symptoms of emphysema and bronchitis. Clinical sign and symptoms of chronic bronchitis patient. What happened there when there's hypoxia, shortness of breath, the infection is more this common in both patients. But when you see the there on examination, there is hyperresonance, there is increased chest anterior posterior diameter of chest X-ray, there is long tubular heart is more common in emphysemic patient. And that is not in case of chronic bronchitis. There is chronic bronchitis patient, there is inflammation, there is risk of more infection, there is risk of pneumonia. So the lung, you can differentiate from the lung X-ray of the patient, and you can, but the sign and symptoms are overlapping, both overlapping, in both having tachypnea, shortness of breath, infection. So, but the sign and symptoms can differentiate from the chest X-ray sign on other labs, and also you can take patient history. DLCO is a test for the oxygen diffusion. Okay, someone saying why there is a large heart. If there is a core pulmonale, that leads to the cardiac failure that causes a large heart in chronic bronchitis patient. Radius index, I taught you the radius index. It is a thickness of glands, submucosal gland between the epithelium and the cartilage. When you see and go back your book, it's a very good picture of the radius index. And read index, and read index is increased in the chronic bronchitis patient. It is basically the wall thickness between the mucous gland and epithelium and cartilage. So it is increased. For example, this is mucous gland, this is gland, this is epithelium, and this is the cartilage. So this is the their length of that histology, or length of histological picture. That is the histology basically. The length is increased because of increased their hypertrophy of the submucosal gland. And is erythropoietin production is increase in both or only it can increase in both? Okay, what is the it can increase in both? Why? Because it is a basic concept. Whenever you having hypoxia, your kidney gives your there's a signal that goes to the kidney, and the kidney release erythropoietin, and then they try to compensate that hypoxia by producing more red blood cells. So there's always there is a normal phenomena. If the patient in chronic bronchitis, this patient is in distress more, so there is the oxygen saturation decreases, and there is a hypoxia that leads to that erythropoietin production. If there is a core pulmonary emphysema, why will be the heart? Because of okay, it's a good question. Who is asking? Aman Tariq. Okay, Aman, I told you that in why heart be small or narrow? Why? Because there is obstruction and there is more air trapping. Because of this, the interior posterior diameter of chest increases. That leads to the shadow of heart like a small and narrow. No, DLCO, it is not for, basically DLCO is monitors by surrogate. Carbon monoxide is a surrogate marker basically, which is used for the monitoring of oxygen, diffusion of the oxygen in the lung. Can you get my point? Carbon monoxide is a surrogate marker which is used in the test to detect the patient diffusion capacity of oxygen. Basically, DLCO is a diffusion capacity of oxygen of patient, but which is monitored by carbon monoxide outside by a test, because that is a surrogate marker for monitoring of oxygen. Okay, thank you. No, only shadow of heart get narrow. It is not actually shrinking. Not shrinking. Actually, it's a shadow of heart that look like in the X-ray like it is a get narrow. Okay, anyone? Okay, thank you.